Mike, that's great work, Mike, and it's good to know that orange is the new red. So that's amazing. Do you do any work at all to see the predictive utility and the predictive validity of the scale? So it's obviously the internal structure is very neat, and there's a couple of abnormalities. But I'm just curious, does it predict anything meaningful?
It's an excellent question, and I have not looked into that at all. I don't know what we would necessarily use it to
Things like relapse, for example, or if there's changes in symptomology.
I don't know if we would have that information available to us, because yeah, like I said, it's all kind of collected through the app. So I'm not sure whether we could get into it or not. I don't know what information's in there.
It'd be nice to see if there's other.
Absolutely. I mean, there's so many different elements that we could look at, but then that's certainly something to consider. Prospectively, risk prediction is a lot better, and we certainly haven't set it up in that way. But we could look at retrospective data to imagine it if we have that data available.
I was just thinking of the baseline data you have, and to what extent it predicts how long symptoms last for, and so there's other objective measures we could also look at. Could be a really nice paper to further bolster how impressive the scale.
Yeah, sure. Make a note of that. Thank you very much.
Yeah, go on.
Mike, have you got a hierarchy? So you've got the symptoms, that looks nice with 3 items. Have you got a hierarchy in the symptoms, like an order?
There will be, because that's kind of half the point of looking at it, but I can't tell off the top of my head what they are. I have it on my computer, so I can check for you if you want to see which one is like the first and the last. Yeah, so absolutely, I can check in the day.
Yeah, thank you very much. It's really, sorry.
It's okay. Okay, now on then.
Same direction. Okay, that's great. Thank you very much. So can I just understand a little bit more about the utility of the sense of smell, taste, and also the cough and the voice issues? I didn't really get that very well. Are we saying that its ability to predict changes in individuals with these symptoms is less compared to its ability to predict changes in symptoms of other types, like fatigue and other symptoms? Because the reason I asked this question, let me just finish with that. I think Rowan will know this, and Manoj, I've shared data where we've looked at the C19-YRS in about 50 patients before and after rehab, and these were the symptoms that are least likely to improve. So I want to know, is it because the tool is not very sensitive at picking up improvements or changes, or is it because actually it's true lack of improvement or changes?
I don't know if it's necessarily anything to do with improvement. So what we are looking at is whether all of the questions within a particular scale contribute to a single total score. And what we found that those 2 questions, it appears that they are measuring something slightly different to what all the other items are measuring. So yes, in terms of what's known as the discrimination between low severity and high severity, the discrimination is not as great for the smell, taste, or the cough max item. So whether they're measuring something slightly different, or whether there's something going on with those items where the curve is a little bit flatter, which means that people, where you are on the underlying level of severity, you still have an almost equal likelihood of responding positively to that item. So they could be just like standalone items that are slightly different. They do contribute still, but not to the same extent as the rest of the other items. So I'm not sure that sort of answers your question, but it kind of adds weight to the same thing, that you found the same thing just clinically, that those 2 items aren't particularly movable, and that's what psychometrics are showing.
Yeah, so I think you're right. This is a reflection of individual items, and it's not a reflection of the overall scale. I think your question is in your data, you're asking about sensitivity of the overall scale. What we're talking about here is individual items, not the entire scale.
That's true. I think in the whole scale, there are these items that appear to be the items that move the least when we look before and after intervention. Now, the sensitivity with what you described is describing the sensitivity of the individual items. What you would expect, even with that, for it to shift a little bit, or not to shift when the other items are shifting, or is it something else? The reason I'm thinking about this in my head and playing it around, and I'm still trying to absorb what it means really, is if we are going to move forward, looking at what are the symptoms before and after an intervention that change the least, then we're going to have to look at what are the changes in the design of our services that need to change to meet the demand in relation to improving these symptoms. So, if we are saying that sense of smell and taste changes the least, do we need to get the input of an ENT surgeon to be, or whoever it is that might deal with that, into the process of rehabilitation to improve these? But if we do that, that means that we may actually make a decision based on inaccurate change in the score. That makes sense.
Yeah, that does make sense. I think it's kind of it's not an argument, but like a circular process, and that's exactly what it's saying.
And I think that relates to the conclusion which Mike made.
Exactly.
You can't exactly change the scale just based on the psychometrics. You also have to see the clinical utility. So if you get rid of those questions, I think we'll be losing a lot. So that's the kind of, we've got to accept that.
But yeah, you're right, and that's where we have observed the least change, and that's exactly what you are saying as well.
Exactly.
Yeah, thanks, Mike. I'm just asking about how do you find the cognitive and the mood symptoms in relation to the functional score? What is their contribution?
So the cognitive symptoms are in the severity, they're in the severity scale, and they operated really nicely. There was no anomalies there, which mean that they are contributing to the overall score, which also includes all the different symptoms that were covered within there actually. So the cognition is working okay as far as we're concerned.
Could we go online, Brendan?
Hi, yes. Apologies for not being with you in person today. A couple of a comment and a question. Really. The comment was around the cough and the loss of sense of smell. And thinking about the review on the pathophysiology that we've been working through, I wonder if probably it's because these are not really part of the core symptom complex with long COVID, and particularly the sense of smell things. Those papers around damage to our factory cells were very niche, very out on a limb, and there wasn't any attempt to link them in. And they're a very common problem that people describe anyway, without fatigue and breathlessness and all the cognitive problems, the things that are more predictive. So I suspect that's what it is. They don't belong in long COVID. The question is, to what extent might your ongoing analyses be able to look at the relationships between symptoms of different symptoms in C19-YRS and the functional impairment on EQ5D to address the question of which classes of symptoms are most impairing for patients? I think we know kind of anecdotally about that, but it'd be nice to see some stuff based on the questionnaire.
Right.
Is that on this?
Yes, on that question.
Okay. Oh, okay. No, Janet.
Right. I think the sense of smell and taste is core to long COVID. I do not think it is not part of the thing. In fact, we've got evidence. We've got evidence to that effect from the long kiss study in Scotland. I'll just trying to find the reference here.
Long kiss.
Yeah, long COVID in Scotland. Long kiss.
What else could it be?
We do wine and smelling.
We do.
That's what I was going to say. Actually, smell and taste wasn't there in the original C19-YRS. Right?
Yeah.
It was included based on PAG advice. So we're not taking it out now.
Yeah, so I think it's key. I really do, and it is a difficult one to get their handle on. But it's actually something which is of all the post-viral syndromes, it's the one which long COVID does, which other ones don't. You don't get it in post-dengue, you don't get it in post-Jick, you don't get it in post-Ebola. But you do get it in long COVID, and it's the one thing that of our, like our heat map type studies, it's coming out as, you know, that is what long COVID is, you know, more than the fatigue, more than anything else.
But that only came on with the later strain. I think it was particular to, I forget which strain it was, but it wasn't the first one by any means, that people started to complain about that a lot.
This is very interesting actually, because this is kind of when I reported it in the LOCOMOTION online meeting. This is exactly what
Before we go to Steve, just 1 second. Brendan, I think the reply to your question about EQ5Ds, that is planned. I think Duncan and Joseph, they are planning some work around linking EQ5D to C19-YRS. So that's definitely in the plan. Sorry, Steve.
I wonder, like, without wading into whether loss of smell and taste is core or not, I think is the point that I can't really think of a patient who would have post-exertional symptom exacerbation but not have a constellation of other symptoms around it that are typical. But I can imagine patients who have loss of sense of smell as a standalone symptom.
Yeah, that's
So
true.
that would explain why it doesn't function with everything else.
Exactly. That kind of thing.
That's kind of what I would probably imagine too. It's like it's there or it's not, but it doesn't necessarily change to a degree.
It is something slightly different to the other things, you know, but I mean, I think it's the same with other post-viral symptoms. There is something unique. I mean, they all have a lot in common, but there are kind of unique things to all of the different syndromes. And this is one which is, I haven't seen it in other post-viral syndromes. It's really interesting.
This is going to give us all some good points to the decisions.
Okay, one final question, Ron.
Just about, has any consideration been given into using the C19-YRS as an individual self-monitoring tool? Reason being is because we get some kind of questions, you know, directly from, I suppose, non-patients that are struggling with long COVID that, you know, dropped us an email that haven't been able to access a clinic, but they have been using, you know, paper-based or online version of the C19-YRS. And the reason why I ask is, ironically, some patients actually do prefer the 10-point scale over the 4 rather, because it does give them a little bit more breadth and kind of, I think they find it useful in kind of, I suppose, looking at that recall bias and seeing what they kind of looked at before. So then with a larger scale, it's easy for them to identify, you know, minor changes, whereas a 0 to 4 scale these are big jumps. Yeah, this kind of focuses on the clinical utility, but what about, you know, people who might not be able to speak to a healthcare professional? How could this be used in that environment?
So I would say that we've kind of seen the empirical evidence that the scale just isn't working with a 0 to 10 weighting scale. So that's kind of based on the collective information that we've looked at. On an individual person level, then it could absolutely work like that. But then we can't compare the scores between individuals. So they're not like they're not invariant scores. So it's the same that with kind of the age-old argument, like goal attainment scaling and things like that. They're brilliant for individuals, but they're useless for any sort of research studies or for comparing different individuals. So, I mean, we can't kind of say, right, if you're looking individually, use this old version and use the new version. So it's a good point, but I don't know that it would be. I suppose people could just use it individually, but that information isn't going to be useful to compare to anybody else. So